Has anybody ever heard of NF1? I don't know how you find it, but if you speak about the condition or mention the name, the vast majority of people will just look at you quite blankly and say, NF what? So yeah, I've been based at the Birmingham Women's and Children's Hospital for, I say 23 years now. So I've been working with NF for a really long time. I've seen lots of changes over the years. So neurofibromatosis type 1, it's not a particularly rare condition. It affects about 1 in 2,000, 1 in 2,500, 1 in 3,000 people. So to be a rare disease, it needs to be under 1 in 2,000 people. And we know there's a huge number of individuals with NF1 in particular. Oh, that's better. It's caused by a change or a variant on chromosome 17, and you only need one copy of this gene in order to inherit the condition. The inheritance follows an autosomal dominant pattern, and that means about half the cases are inherited from a parent. So you've got a 50-50 chance, if you have a parent with this condition, of inheriting NF1. There's about 26,500 people with NF1, and that's quite a lot of people. But if you think about it, a GP, and we all know it's difficult sometimes with GPs, they are generalists, they're general practitioners, and they may not have the knowledge of a condition like NF1. And in all honesty, they have a lot of genetic and other conditions to deal with. So I think it's part of our job to try and make this as easy as possible for them, and certainly for our patients to get the right sort of help and advice. It's not always easy. Say it's not such a rare condition, but has anybody ever heard of NF1? I don't know how you find it, but if you speak about the condition or mention the name, the vast majority of people will just look at you quite blankly and say, NF what? So, I mean, I remember doing a genetic counselling course, not in this job, but in a previous job, when I was looking for genes for type 1 diabetes. And I went down to Great Ormond Street and did a genetic counselling course, a 2-week residential course. And I came back from that course with a massive folder full of loads of different genetic conditions. A couple of years later, I saw this job and I thought, oh, I fancy doing that. It's kind of similar to what I had been doing, but a bit more involved with patients. So I thought, right, I'm just going to go back to my folder. It's got to be in there. And I ploughed through this folder trying to find information about NF1. No information whatsoever. It hadn't been mentioned at all. And that's on a genetic counselling course, and it's not one of those conditions that is particularly rare. So there's more people with NF1 than there is cystic fibrosis, Duchenne muscular dystrophy, and Huntington's. Now, most people have heard of those, haven't they? Most people will know of CF, even if they don't know the details about it. I think another issue with that, which is actually a good thing, is the fact that the majority of people, around about 70% of people with NF1, are quite mildly affected. So they may just have some cafe au lait patches, 1 or 2 not so difficult problems, and it might not be something that they choose to share with people. And if they don't have many neurofibromas, again, and many people don't, some people do have lots, but it's very variable. So if they don't have many markings, they may choose just not to say. And therefore, I think it goes under the radar. They don't tend to go to their GP, and in fairness, the GPs don't have that much information for them. But then there's around about 30% of people that are quite severely affected with NF1. And for those people, we have complex clinics where they can be directed and seen by experts who really understand this condition and the implications. So I think a lot of it is the fact that many people are fairly mildly affected, and that's how I sort of understand it as to why it hasn't been so well known. So as for the diagnostic criteria, it remains the same, but it's been sort of highlighted to ensure that we exclude a condition called Leaguer syndrome, which is quite similar to NF1. And hopefully this should make it easier for people to see what the criteria is. So in this case, for a child who does not have a parent with NF1, so there's no history of NF in the family, you would need 6 or more cafe-au-lait patches. These would need to be bigger than about 5 millimetres or 1.5 centimetres in an adult, so 5 millimetres in a child. You'd need more than 2 neurofibromas or 1 plexiform. Axillary or inguinal freckling, I've got some images of these to show you in the next couple of slides. 2 or more leash nodules that can be identified by a slit lamp, usually by an ophthalmologist or an optometrist, or 2 or more choroidal abnormalities, and these are just things that we picked up. I don't think they're necessarily of any significance, just the same as leash nodules, which are completely harmless, but they help us to delineate who has NF1 and who most probably doesn't. So that's a photograph of the leash nodules, and often people say to me, oh, I could see that they've got leash nodules because they've got these little patches in the eyes. But you can't actually see them with the naked eye. But I understand what they mean, because you can see some people do have that sort of colouring, and you'd be excused for thinking they might be the leash nodules, but they're not. So the leash nodules, as I say, they use a little slit lamp to be able to identify them. They're generally not present at birth, and you wouldn't be able to do that sort of an examination on a baby anyway to see them. So, but about by the time they're about 5 years of age, they will be, about half of them will be visible, and 90% of leash nodules are visible by the time somebody's 25 years of age. I think the importance of these, or the help that they give us, is that probably about 98-99% of people with NF1 will have leash nodules, and people without NF1, it's very rare. We do see it, but it's very rare that they have them and they don't have NF1. So they just help with the diagnostic criteria. So, image of the cafe-au-lait patches here, and some of the neurofibromas. And as we know, everybody is affected differently, so it's really difficult to predict how many neurofibromas someone's going to get and where they will occur. There's a lot of talk and confusion about removal of neurofibromas. I feel really strongly that this is not just a cosmetic thing, and indeed it says on our guidelines that it isn't. Many of these neurofibromas are really troublesome. They catch on clothing, they're itchy, they're painful, and they bleed if not. So it's something that I'm continuously doing, writing letters to GPs, drawing their attention to the fact that, look in the clinical guidelines, please. It's not, this isn't something that people have done for a cosmetic reason. It's a lot more to it than that. So back to the diagnostic criteria and more of the features of NF1. So again, this is for a child who doesn't have a parent, because if you have a parent with NF1, that counts as one of your criteria and you only need 2. So if you have an optic pathway glioma, and that's something that we usually pick up, if we haven't picked that up in a child by the time they're 8 years of age, it's very unlikely that we will, or that they will have one that's going to progress to cause them problems. We also look for a bony lesion called a sphenoid wing dysplasia. That's actually quite rare. We don't see it that often. And that means that there's a malformation of the bone sort of around the orbit. That can cause a proptosis of the eye, and it is also a plexiform there, which there is in some cases. That can be quite complicated to deal with. Bowing of tibia or pseudarthrosis of a long bone, and that again is a rare complication, but we do see that, and that can be very tricky to deal with. It can result in lots of surgery and lots of braces and things used, and so it's quite a difficult one. And also, of course, if they have a blood sample taken and we find the NF1 variant in their blood, that's also one of the criteria for diagnosis. So the other complications are hypertension, epilepsy, and scoliosis. In the case of hypertension, it's really important for everybody to have their blood pressure taken at least once a year. And there are a couple of complications. One is a pheochromocytoma and also renal artery stenosis that can shoot the blood pressure up very high. They are quite rare as well, which is the good news. And that's why we generally only say you need to get it checked annually, because it's not that common. However, I would urge people to get their blood pressure taken on a yearly basis. Ask their GP, perhaps if they can be seen by the nurse, to have that done. Because if there is hypertension, there could be other reasons for that totally unrelated to NF1, but it's just helpful to know. And it's helpful if the blood pressure remains high, that you get it checked and find out what the underlying cause is. And then just a couple more images of some freckling under the arms and also in the neck area. We can see that. And we can also see inguinal freckling in NF1 as well. Some more images, some cafe au lait patches at the top two. And we've also got some neurofibromas. And so we've got the neurofibromas that are obviously visible on the skin, and then the ones that are subcutaneous and remain under the skin, although you can see them. They're all a type of neurofibroma, and there's nothing, there's nothing that's wrong about either of them. It's just that they're different ones. There's also the sort where you put your finger on where a neurofibroma is, but it's actually not outward, it's kind of inward. So you can get quite a jelly sort of feeling. And I don't know if anybody recognises that, but that's actually fine as well. They're healthy. That's not a problem. So back to, if we have a child with a parent who has a diagnosis of NF1, then really you only need one other feature of this condition. So if it's cafe au lait patches, it could be the issue that we worry about is, as I've mentioned, we don't want to confuse it with another condition called Legius syndrome. This condition was first noticed by a chap called Professor Legus. He's a geneticist in Belgium. He's done a huge amount of work in this area. It is found on a completely different chromosome. It's found on chromosome 15, but it's very similar in many ways. But there are also a lot of differences, so we have to make sure we get the right diagnosis, which is important to know whether a parent has it or not, whether the pigmentary changes that you find in the axilla, under the arm, or in the groin area are on both sides. And it sounds like we're being a little bit, sort of picky about things, but it's really important because in Legius you can often find they are just on one side, but with NF we generally find that they're on both sides. And if they're not, we have another feature that we can say, well, yeah, there are at least two features. The other big difference in Legius is that they don't develop neurofibromas, and there are quite significant learning difficulties associated with this condition and some heart issues as well. And some of the more minor features are things like a short stature and a macrocephaly, or a larger head than usual. And that's noticeable when people are younger, but as they get older, that sort of, the proportions kind of even out, and it's not something that is generally noticed as people get older. So a few years ago, I started to work on the Helpline. So I'm based in clinical genetics for 2 of the days and then working on the Helpline on 1 day. It's open from 9 to 5. I would urge anybody to give us a call if you've got any questions, any queries. There's no silly questions, and sometimes people just want to have a chat about things, just talk things through, things that they're experiencing with somebody who gets it and who is not going to be asking them to explain what NF is, because you probably ask that a lot over your life. Telephone number's up there. It's also on the website. And there's also a free phone number now. And I think I'm right in saying that you just need to check for your particular service provider to make sure it is still free for you. And I'm always happy if anybody wants to email me or even just bell me and say, can you ring me back? That's fine. I often email people and just say, give me a number and I'll give you a call if that's easier. So, yeah, I think, we have many functions on the helpline, but I think one of the main functions I find with individuals and families that I speak to is that it's just helpful not to have to explain things all the time, because I think you spend most of your life doing that. And that's whether you're mildly or even severely affected, because whenever you broach a subject, people just don't know and don't understand. And that can be quite difficult, I think, to always be on the back foot to somebody always having to explain what this or that is. I often get a lot of family members calling, sort of doing that initial call before their, I don't know, son, daughter, brother, sister will get in contact, someone who they'd like to speak to someone, but they're not sure whether they will. And often, I'll have a chat to whoever it is. We'll talk about not their specific case, but we'll talk about NF in general and maybe clarify any confusion or any other things. And that can be really helpful for families. Perhaps they're worrying about something that they need not worry about, and we can clarify things for them. And also, most of the time, they would encourage their relative to call or to arrange for me to call them. And I'm very happy just to have a chat to them about whatever it is that they want to find out more about. We're also involved in the Inform process, which has been set up with schools so that on the helpline, and also for the specialist nurses that are based all over England, so that people can come to us, have a chat to their school, get us involved. And if we're not local, which obviously we're not to lots of parts of England and the UK, then we can do a virtual school visit. So this is really helpful. It involves a lot of work behind the scenes, making sure we understand about the child, what the issues are, how we can help, the sorts of problems that have been happening at school. If indeed there are problems, there aren't always, there are lots, but sometimes it's just getting to know that individual child and what works for them and the sorts of problems that they might have, so that we can help them out with that. So I'll be doing a lot more of that, because what I didn't say is that I'll be leaving the NHS at the end of October, and I will just be doing the helpline from then on. So that's going to be a big change for me. That'll be something quite new. But I'm looking forward to that. I'll be doing lots more of Zooms and things like that as well. So on the helpline, we liaise with literally anyone and everyone, from people mentioned there to, employers, to anybody really who I've got involved with British Rail, and I put on information about NF, particularly for several members of staff where I think one had autism as well as ADHD, and so there were lots of things there. This member of staff was really highly valued. He didn't think he was. He thought that he was a bit of a nuisance to people. And I think what he found was that his special kind of interests, which were trains, were noted by everybody. And, one of the highest managers said to him, if we need any information, we come to you, right, as the train managers, because he had a dictionary of where all of the trains go and where they cross and where you have to get off one and get a ticket for another one. And so, yeah, his knowledge was incredible. And so things like that can be quite helpful. I've gone into lots of places, actually. I've gone into hospitals, I've gone into McDonald's and had a chat with the staff there. I think particularly things like, things that will make things easier for that person. So it might be making sure the employer understands that they might have short-term memory problems. So it might be easier to write certain things down for them, just to make it a bit more doable. And quite basic things at times, but also it means that often the person themselves doesn't have to do that whole blurb about themselves. And sometimes that can be quite intimidating and quite difficult, I think, in a new job. Also send out clinical and annual review guidelines to GPs, and also send out information to families in particular, stuff that they can take with them to their GP or to the next consultant that they see. We just want people to have as much information as possible and to spread that as widely as possible. So it's critical that they've got, up-to-date and accurate information in order to do that. We get calls from tons of people, clinical geneticists, obviously parents, teachers, GPs, getting a lot more medical staff calling us, particularly from outpatients when they're seeing children with NF1, which is great. We welcome that. I'm not going to go through and name all of these people, but what it also shows to me is that many parents and children with NF have a huge amount of people to see. So you might have a GP, you might have a nurse, you'll definitely be seeing a neurologist, you might need to see a neurosurgeon, you'll be going through the outpatients and seeing, your annual reviews. There's a lot of people to get involved, and the more complex the NF1, the more people are often involved. And that takes a lot of time, and it takes a lot of getting your head around in terms of appointments. And we know that organisational skills can be difficult for people with NF1. It's something that, as try as they might, it can be very, very hard. So if you can imagine having a child and having all of these people to coordinate appointments for, and often it is a huge number of people. They might have a couple of children and they might have NF1 themselves. So I always say to people, think about that. Think about when they're coming. Is it okay for them? Can they fit that in? It's really important. It's not, if they don't turn up, it's not because they can't be bothered. It really isn't. A lot of the time it will be, they've missed the date or something's come up like that. So I think it's really important to support people with those issues. We know about them. So also we do lots of signposting. So there's tons of organisations where, I know I've had experience with the people from that particular charity. There's one called Eric, and that deals with lots of bladder and bowel problems for young children. Some of them are NF related. Some of them are actually just because they're young children, and that's really common issues, So if you've got an organisation that works really well with people, then they're the ones that I would recommend to people again and again. There's also places where you can get things like, equipment, lots of things that you might, sensory rooms. You can get these for free from places like New Life. And we've got lots of all of that information is on our website for people as well to have a look. Changing Faces are an amazing charity. Most of the people that work for them and that do the information days like today will have a visible difference. I think that's incredibly important. And I've been to a few of their talks and I found them really moving. And I think the key thing with the people that are doing the talks for Changing Faces and to people with a visible difference, which might be as a result of anything, it could be an accident, it could be a genetic condition or whatever, is the fact that that person speaking to them knows exactly what they deal with. And that's incredibly important. And, I think they've been so moving, and the feedback they get is great. A lot of emotion in the room, but they'll just talk through ordinary everyday things like comebacks. Give this comeback if somebody says that to you, and it might be quite a small thing, but it's just really, really helpful to know. We've also been working with the Centre for Appearance and Research in Bristol, who are doing tons and tons of work in this area, and again, it's for people that have a disfigurement of any kind. It might be a medical related, it might be burns, it could be anything. And they're really making moves and making some important differences for people. So we know between about 30 and 60% of children have problems with handwriting. I think these are some of the most sort of standout things for me in terms of when I talk to parents and children with NF. Handwriting difficulties, a lot of that can be due to the fact that It's very difficult. Their manual dexterity isn't so good, so it can be difficult to form the letters. It takes a really long time for them to write. And, 2 or 3 lines feels like an essay for them. And it's really important to understand where they're coming from. So in cases like that, depending on the severity, we would recommend, as they get older, maybe using a word processor in school so that they can hopefully start at the same point as their peers when they're trying to write things up. And if the other alternative would be for them to have a scribe or amanuensis in exams. If that's going to be the case, that needs to be sorted quite early, because that again is a skill in itself. The child would have to not only dictate what they want to say, which I think can be quite difficult if you haven't got it written down. They dictate what they want to say, but they have to make sure that they put all the full stops in and the commas and the next paragraph. So that in itself is quite a skill and takes a while to get that sorted. So we mentioned about poor concentration and short-term memory deficits. I think the number of times that I've done school visits and parents have spoken to me, times tables is the one that comes up the most, I think. And they'll say, we've practiced this at home every night. And, she had them down. She got them all. And we're so proud of her. She went into school on the day and she got them all wrong. And the teacher's thinking, God, they haven't tried, have they? They've not even bothered. They haven't even looked at this. And that they have looked at it and they've been spending a huge amount of time. But we know that in NF1, sometimes it's not quite there. They go to, to do the test and they don't get the majority of them right. And they get really disappointed because they know they learnt it. They know they had it. And, a lot of people will be saying, well, you obviously haven't worked very hard on this, have you? Unfortunately. And they're probably the ones that have worked the hardest in the class. Deficits in motor skills, gross and fine. We know that comes with NF. And Thomas was saying about not, difficulties riding a bike when he was very young. And the fact that he still can't now. And that's the case for many of our people with NF. Physio can help with that. But again, it's a case of, can you get that physio? And sometimes that we can get that in school where they're, practicing throwing and catching and threading through things, which helps with their manual dexterity as well. Hyperactivity and impulsivity also go with NF1. And I think in terms of hyperactivity, we're thinking of attention deficit disorder as well, because we know that up to 40% of children with NF1 also have attention deficit disorder. We know that many of them also have autism. Generally, it tends to be a form of autism that means most children with this have a normal range of intelligence, but they just find it slightly more difficult than the average person. I think is probably the easiest way to say. There can often be difficulties with spelling and maths, going back to the times tables, and children can be affected in either one or all areas with different amounts of severity depending on the individual. We get involved from the point of view of liaising with teachers and with SENCOs, anybody at school who, the form teacher, head teacher that we can get on board to listen to the issues of NF1, and we will liaise with them and arrange to do a Zoom. So we'll have a Zoom meeting with teachers, the parents of the child, and just to raise awareness and also to give them a point of contact if they'd like to come back to us at some point in the school year to talk about things further. So parents often ask us about what sort of help can they get, and can they get an EHCP? Well, we know that's like as rare as rocking horses, I think. At the moment, I think, this is sort of everywhere. It's impossible to get appointments for an educational psychologist. It's really difficult to get an appointment for CAMS, I'm sure you're all aware the waiting lists are I think the shortest waiting lists are about 2 years, and some of them go up to 8 years. We have been able on occasion to direct people towards charitable organisations for looking at an ADHD diagnosis. There's a fund from Staffordshire, which I think it was a chap called John, who had our mobile phones, and so it's his sort of children's charity, but he also does things like paying towards getting an assessment. It is expensive. It's a lot cheaper than having to do it by yourself, but that information is available, and if anybody wants to talk to me about that, I can give you that. But it is really difficult at the moment. The waiting lists have just gone crazy. Yeah. So often teachers ask me about the different strategies that they might need to use for a child that has NF1. Perhaps they might have attention deficit disorder, and they might have autism as well. And they sort of think, well, what do you do with all of this? And actually, it's very straightforward. So if a child has short-term memory difficulties, then you would support a child like you would any child that has those difficulties. Again, if you're supporting a child that has autism, there's nothing particularly different or special about our NF1 and autism. So you would treat them as you would any child that has autism. And use any teaching strategies to support that for them. And the same with ADHD, attention deficits. If you don't have an educational healthcare plan, and they are really difficult to get, but again, I'd urge you to try and get as much support as possible from people like myself. Get in contact with us, see what we can do to help you. But if you haven't got any HCP, and if your child definitely wouldn't qualify because they perhaps are, they're managing to keep up and they're doing okay as far as school is aware, there is something that you can invoke called the special arrangements, and those arrangements will allow up to 25% extra time for that individual to do their exam. It will allow for a reader, so that the reader can make sure that they've understood the question, and they can have a scribe. But again, going back to that, what I said earlier, if you're going to do that, that does need to be set in place. It's a whole different skill in itself for people to learn. And that should be in place by year 7. And if you get an EHCP, big congratulations, because it's very difficult to get. And also it does need to be reviewed annually. And often patients come back to us just with information for that. And anything that's going well, anything that's not going so well. Just wanted to briefly mention some of the new developments in NF2, the new name. So we're now calling it NF schwannomatosis. A drug called Avastin has vastly improved survival rates. I don't do the NF2 clinics anymore. I haven't done them for a number of years, but it is can be a very severe condition. And we've also got another drug called brigatinib, which is now being used to treat NF2 meningiomas and schwannomas. In NF1, we have a drug called selumetinib, which is used for inoperable plexiform neurofibromas. So this is an amazing advance, if you like, because that can be given to children from the age of 2. So it's something that is up and running, and certainly from our children's hospital and all throughout the country who are taking part in that. And then finally, I wanted to mention something that's dear to everybody's heart, I'm sure, and that is that there are new trials that are underway in adults. This is in the USA at the moment. It's called it's NFX179 gel from Nflexion Therapeutics. It's applied topically. It's a clear gel, and they've been looking at this to see if we can reduce the size of neurofibromas just by a topical gel or cream, and it's having some really good results, I'm pleased to say. So it's starting to be something that we can talk to people about. It's in the States. People are taking part. They're seeing big reductions in the size of the neurofibromas, and I just say keep your eye on this. It will come to the UK, and there will eventually be some clinical trials in the UK. The website is ctf.org, where that is. But keep your eye as well on our website, and we've got some research information that I just wanted to mention as well. Yeah. Selumetinib. Yeah, it's called a MEK inhibitor, so it prohibits the growth of the plexiform neurofibroma. Yeah, if the plexiform, it will reduce the size of a larger plexiform. So it's essentially there for what we didn't have anything for before. So we didn't have anything for inoperable plexiforms. So if something was quite large and impinging on other structures in the body, it's that, there'd be many occasions when we couldn't do that, when we wouldn't be able to help. But this is something that's new. It's been around for a while, and it's been used on children for a number of years as well now. No. Probably in the last 5, I'd say. In the last couple of years, we see a lot at the Children's Hospital. Yeah, so it started to come through. And it's working well. It's tolerated well. It's in tablet form. It is a chemotherapy drug, but it seems to be. Sure. I've got a lot of information on that as well, but I could talk to you about that afterwards. Yeah, there can be some gastro problems, but it's definitely worth speaking to somebody who could just see, to see whether or not that, you'd be eligible for that sort of thing. Talking about research and getting information from people, there's lots of information on the NF website on nerve tumours. There's some amazing webinars, if you look in the research bits, that you can kind of dial down and get information on whatever it is you're particularly interested in. And I think the sorts of surveys that we're running are really helpful, because they'll give people information that they need, and for us to be able to say, well, look, we've asked people what their opinions are, or what they're finding, and this is what we've got. So I would say, if you can let us know how services work or don't work for you, that's really helpful, because it's something that we could take forward. And we also would like to know from families, parents, if we've made a difference, if we haven't made a difference, how we could have done that better. And all the responses on those are anonymous, so do feel free to take part, please.
The National Helpline plays a really important role in what we do and in people's NF journey, particularly for those who do not live in an area of the country where there is an NT UK funded regional nurse. We live in a virtual world now. Not everyone can deal with the virtual world. Talk to us if you can't, and we will try and get around it. But basically, there's nothing that my helpline specialist nurses can't do that the regional nurse does. So they can hold school meetings, they can hold employers meetings, they can hold university meetings. Ask us and we'll find a way to help you with whatever you need. The helpline also plays 2 really important roles, as well as being the virtual nurse. For areas of the country, for newly diagnosed people, there's often a very long wait between a tentative diagnosis and when you actually see specialist services. For areas of the country where there's no specialist services, it's even worse, and you will have lots of questions, you will have lots of worries. If you ring the team, they will help you get through that process. And it is also very important in a time of crisis as well, because something suddenly goes wrong sometimes. You cannot get a hold of your GP, your paediatric consultant, your neurologist. Call the helpline and they will be able to help you. And if needs be, they will be able to intervene and get you through to the right person to talk to. So please use the helpline. It's there totally for your use. It's also there for the use of your allied healthcare professionals. So if you find some of them don't quite understand, even your dentist, if he doesn't quite understand, they are free to call the helpline. These ladies are clinical nurse specialists. They know the subject. they will be able to help. So please do use the facility. It is really important. Now, it operates Monday, Wednesday, Friday at the moment, but we also operate a triage system on a Tuesday and a Thursday morning when the helpline goes through to the head office. Now, none of us are medics, so we won't and can't give out medical advice, but we can book you into an appointment. For instance, if you work, we can book an appointment for the next day for the nurse over your lunch hour, or sometimes people want to make calls when the children aren't at home, so we'll make sure it's in school hours. So please do use the facility. It is, I cannot stress how important it is. It really is, especially the intervention. We recently intervened, didn't we, with a lady from Scotland who was being dismissed from her GP. They just kept telling her she had a headache, go away. Turned out she had a brain tumour, but because it was the intervention of my team that they had to listen, and we got them through to specialist services. And I have to say, in the nick of time, wasn't it? So it's a very valuable resource that we have. So please do use it. So, and in terms of areas of the country where Carolyn and Rebecca cover virtually, we are working to get nurses in that area. But there's two problems we always face. One, I've got to have the funding in place first, and I've got to have 3 years of funding to set up a new post. But also the harder one is getting an NHS unit to work with us to house our nurse for those 3 years, because it's so important. I think Carolyn will agree with me that the nurse is housed within an NHS unit, because then they have access to medical records, because the condition manifests itself so differently. There is no point being a generalist in NF. We need to be housed in an NHS unit with access to medical records so that we can be patient specific. It's so important, but that's we've got 2 more new ones in the pipeline at the moment. Once we've agreed them, we will get them out. But I think it's probably going to take in the region of 5 years to get coverage of England and Wales. Scotland do it slightly differently. Okay, so we will take questions at the end, if that's okay with everyone. So Carolyn, thank you ever so much. Thank you.